worldwide tuberculosis infection statistics from 2016 as per WHO. And you can see most of the parts of the world have tuberculosis, especially sub-Saharan Africa. This is because of the HIV. This part of the world is seeing most of the tuberculosis. Other hot parts, we are included in that part also. This is Pakistan, India, and Bangladesh, Nepal, all those parts. These South East Asia is a hotbed, and we have 200 to 300 cases per 100,000 population. So it's quite significant. Each and every week we see a case of tuberculosis. And tuberculosis is common, but it is a clinical challenge for each and every physician who's doing clinical medicine, because establishing the diagnosis of tuberculosis is not easy. This is something we have to understand and appreciate. Why? That is because first you have to establish the diagnosis of tuberculosis, then only you can manage it. And management is complicated, especially in 2021 with tuberculosis resistance. We'll just briefly touch on the resistance. It's a big challenge, and exposing people to multiple medication for long duration of time, it's adds furthermore to this challenge. All of these medications, they are chemical compounds which have side effects. Also, if the patient is not compliant, is not taking the medication regularly, there are chances of development of resistance. So all this has to be taken into account, and we have to understand that diagnosing tuberculosis is a real challenge, even in people, even in countries like Pakistan, where TB is endemic. We'll just briefly touch about basic microbacterology. It's an aerobic organism. It's non-spore forming, non-motile, slightly curved. Classically stained with Ziehl-Neelsen quinone, and now more commonly because of the yeast fluorochrome methods. Okay, but for examination purposes, you have to remember AFB, acid-fast bacilli, are stained by Ziehl-Neelsen stain. Okay, but practically when you go to the lab and you see, most of it is being done by fluorochrome methods. It's easier to do. It appears something like this, a red appearing rod-shaped organism, slightly curved. Okay, so red, if it is a gram stain, you worry about gram-negative bacteria. But this is not a gram stain. This is a Ziehl-Neelsen stain showing the mycobacterium. So this is just for your information. Very, very important. Transmission is by airborne mucus droplet. So this has to be understood. Most of the infectious diseases, either pediatric or adult, they are classified according to the mode of transmission, how they are transmitted. Right now, we are, alhamdulillah, passing through a descending fourth wave of COVID. And everyone knows that COVID is by respiratory droplet. So it's not airborne. If it was an airborne, then we were in major problem. When anyone passing through this room has exposed everyone. There are 3 diseases everyone should know, especially in pediatrics, which are airbornely transmitted. First is tuberculosis. Second is measles, which is also endemic in Pakistan. And right now we are seeing a lot of cases. And the third is varicella, zoster, chickenpox. All of these three conditions, they are airborne. There are droplet nuclei which can remain suspended in the air for long duration of time, hours. And anyone who's in the vicinity, he's exposed and he will become infected if he does not have a proper immune system or he has not received a vaccination. So this is important to remember. This is also important to remember when we are admitting cases of tuberculosis. Tuberculosis patients should be admitted to a negative pressure room. Okay. And in each and every hospital, we have special wards. Here in special 3, we have negative pressure rooms, which are equipped with special filters and exhaust systems that the air of the room is sucked out and goes out of the hospital directly, safely. It does not come out of the door and it does not expose the other people who are in the hospital or who are visiting. So for TB, this is one of the points you have to learn. Pick up some points from this lecture which are essential. Is one of this is airborne disease. Majority of infected children are not contagious. This also is different from the adults. Adults have cavity diseases. They are coughing up. They are bringing up sputum. Sputum particles are being expelled forcefully when they cough. Children, they don't have cavity disease. They are usually presenting with higher lymphadenopathy. Okay, so they are not, and also they don't bring up sputum. If they bring up sputum, they swallow it. They swallow it and it goes to the stomach. It does not go outside. So, and this cavitary TB, which people are coughing around, it's the most important marker of contagiousness. If someone is diagnosed with TB, he is put in a negative pressure room, isolation, and we repeat his sputum cultures and we see when he becomes smear negative and he can come out of his isolation. Pediatric patients are not infectious. They don't have cavitary lesions. They are not coughing up sputum containing tuberculosis germs. But pediatric tuberculosis is a sentinel event, which means that these patients, they are exposed to someone who had open TB. In the family or where they are living, there is someone who has TB, who's coughing up TB organisms, and this child has developed tuberculosis secondary to that. So that's very important. Child diagnosed with TB, we have to investigate the other family members, the contacts, the school people, who is the primary source of TB. And when we screen like this, we find out many people. Sometimes it's the household mate, sometimes it's the grandparents, sometimes they are the parents. And we find out the other siblings are also affected. So pediatric tuberculosis is a sentinel event. When is the patient no longer contagious? This is very important. The patient has to go back to school, has to resume other activities. So there should be clinical improvement, decreased number of AP organisms in the sputum, changes in radiograph that take long time, adherence to the treatment. This is the most important. If the patient is taking treatment for at least 2 weeks regularly, then we assume that he is no more infectious. He can come out of the isolation, he can mix with other people, and he can start his usual activities. Pediatrics TB, 1.3 million cases per year, significant number also, significant number of deaths, 400,000, okay. But there are special people who are at a very high risk of developing TB. And any child who is exposed to these people will also have a very high risk of developing TB. So, who are these people? These are people who are living uh, close together with poor hygiene. People are living in jail, okay, homeless shelters, people using illicit drugs, which is becoming very common. You see when you pass by when in traffic underneath the overhead bridges and flyovers. There are many people who are using drugs. These people are at a very high risk of developing uh, having TB, and anyone who is exposed to them will develop TB. Socioeconomic disadvantage. These people are malnourished. They are living high density areas where there is poor hygiene. So they are at a risk of 10 to 20 folds higher than the other population. That's the importance of taking a good history, socioeconomic history, social history, family history, exposures. When we're taking the history, asking about exposure. Has the patient been exposed? And when we are taking the history and then we are considering TB in our differential diagnosis, we have to ask specifically, anyone in the family has TB. And you have to ask about two generations, parents, grandparents, anyone, or other uncle, maternal granduncles, paternal granduncles, anyone else, anyone in the family who has been diagnosed with TB or has signs and symptoms of TB. Either he was diagnosed or he was not diagnosed. So this is important. In pediatric tuberculosis, 60% of the children are younger than 5 years of age. This is scary. So that's very, very important. So most of the patients in pediatric age group, they are less than 5 years of age. Higher risk in children older than 14. So between 5 to 14 years, there is low incidence. In younger children, gender ratio is equivalent. Female and male both are affected. But in older children, girls are at a higher risk of developing TB. There are many other causes. One of the main thing is that malnutrition is more common in girls because of our culture, uh, preference given to males. Most of the girls are malnourished and then they are exposed to TB and they develop TB. Other important thing to remember is that infants and younger children, children less than 4, they present with meningeal or disseminated TB. CNS TB, okay, so this is important. This is very important to remember. This is a devastating disease. If it is not diagnosed early on, child will develop cerebral palsy, CP. He will become permanently uh, damaged and will have limited mental capacities and physical activities will be limited. However, the adolescent TB is just like adult TB. They present with pleural, genitourinary, or peritoneal TB. TB can affect any part of tuberculosis, can affect any part of the body. You name it, bone, skin, genitourinary organs. Okay, so eye, any part of the body can be affected. Clinical manifestations, they depend on which organ system is involved. So it will depend on if it's intrathoracic, pulmonary, or pleural. Most of the people are familiar with this type of TB, pulmonary TB. So when you are asking in the history, you have to specify, ask uh, the parents or the guardian, what type of TB the one who had TB had pulmonary TB, abdominal TB, genitourinary, even it can be congenital. mother had untreated tuberculosis during her pregnancy, and the child is affected in utero with tuberculosis. Pulmonary TB is one of the common presentations, and signs and symptoms are usually minor. They present with any pneumonia-like picture. So, but history is prolonged, and when we take the history, we find out that someone in the family has TB. So that's a red flag, and that's the reason of taking a very good history. Uh, Many things can be ruled in and ruled out depending on how good the history is. So more common in infants and young children, making it more difficult because they cannot complain. Non-productive cough and mild dyspnea are most common symptoms. And when you do the workup after history, physical examination is usually unremarkable in most of these patients. Only in advanced disease, these patients are severely malnourished or cachectic, okay? Or they have added sounds on the respiratory examination. Chest X-ray is usually done. Enlarged hilar lymph nodes or localized hyperinflammation atelectasis secondary to pressure from these lymph nodes. Rarely you see lobar pneumonia. Any child who is having pneumonia, TB should be in our differential diagnosis, and especially if the family history is revealing that there is someone in the family with tuberculosis, then we should be on high alert and we should rule it out actively. Miliary TB or disseminated TB is, alhamdulillah, not common, okay, but still you have in your differential diagnosis, especially in patients who are presenting with fever of an origin, long, prolonged fever. These are the patients who are presenting with classical signs and symptoms: prolonged fever, nighttime sweats, a low-grade fever, okay, more than 15 days, weight loss, all those things. This is due to lymphohematogenous dissemination of the tuberculosis SFRs bacilli. Occurs when massive mycobacterium occurs, usually uh, affecting more than two organ systems: lungs, liver, spleen, bone marrow. Okay, occurs 2 to 6 months after the primary infection. As I said, more common in children less than 5 years of age. And classical symptoms. But the most important thing to remember is in overwhelming TB, the skin test, Montoux skin test, or the TST, tuberculin skin test, as we should call it right now in 2021, tuberculin skin test. It should not be called PPT, it should not be called Montoux test. It can be negative in 30% of the cases because of the poor immunity. The T cell function is energetic, and we don't have that positive. Central nervous system TB is, as I told you, it's a very significant devastating disease. It's also because of the lymphohematogenous dissemination. Extremely rare in children less than 4 months of age. Why, we don't know. But most common between 6 months to 4 years of age. Okay? And there is formation of cases lesions in the meninges and cerebral cortex. Complications are hydrocephalus, syndrome of inappropriate secretion of ADH, antidiuretic hormones, so they are presenting with electrolyte imbalance, seizures, and they have permanent neurological deficit. There is a classification for CNS TB: stage 1, stage 2, stage 3. Stage 1 is non-specific, you cannot tell what's going on. You can only tell there is some CNS involvement, irritability, drowsiness, focal neurological signs are absent, but the patient may lose milestones. Second stage is classical signs of meningeal irritation: lethargy, local rigidity, irritability, seizures, hypertonia, vomiting, or there might be cranial nerve involvement. This is the stage most of the patients are presenting to us. Stage 2. Okay. Stage 3 is a complications of the CNS TB. The patient might present with coma, hemiplegia, paraplegia, hypertension, decelerate or decorticate posturing, progressive abnormalities of the neurological and the vital organs, and eventually death. So it's quite significant. Prognosis depends on the stage. That's the reason of staging the CNS infection. The higher the stage, the poorer the prognosis. That's same here. Congenital TB is rare. May mimic sepsis. So it's very difficult to diagnose. Pediatric infectious diseases should be consulted, and these patients should be taken care by specialists who have experience. So how you diagnose them? I told you upfront that the diagnosis is the most crucial thing, because once you diagnose, you are committing to a treatment of long duration, 6 months. If it is a simple TB infection, which is susceptible to all drugs, if it's something like CNS TB, 12 months, bone or other organ involvement, 9 months, or if it is a resistant TB, 2 years. So diagnosis should be very solid. And that's the reason I mentioned many things here. We do the tubercular skin test, okay? It remains one of the backbones of diagnosing tuberculosis. Okay, it's cheap, it's available, it can be done easily. Sputum smear, difficult in children less than 6 years of age. They don't break up sputum. There are means and methods of inducing sputum which are not usually recommended for everyone, because TB is aerosolized by these methods, and the people who are doing these tests, they are exposing themselves to TB, and they might get the TB themselves. Gastric aspirates are done, okay, because children are swallowing their sputum. So what we do is we take early morning before they get up, they stand, they eat anything. We pass energy, we aspirate the gastric content, we send the gastric contents for AFB strain and culture. The yield is poor. If it is done three times, 3 consecutive days, yield is around 30%. So nothing better than nothing. Culture is the gold standard still, but for culturing you need good specimen, either sputum, bronchoalveolar lavage, or a biopsy or something. So until and unless you have a good specimen, you cannot culture TB. In 2021, every effort should be made to culture the organism, because this is one of the methods by which we can test the susceptibility of the organism to different drugs and tell what is the organism susceptible to and what is it resistant to. And we can change or tailor our antimicrobial or antimicrobacterial treatment according to the culture results. Very, very important. Every effort should be made. Empiric use of anti-tuberculous medication should be avoided. All these things should be done. Now, with the newer technologies being available at affordable cost, we are moving towards more and more methods of nucleic acid probes, PSPCR, also interferon gamma release assays. These are becoming more and more commonly available. Still expensive. I think Agra is around 9,000 right now. PCR and other things are also coming up. And also the good thing is that for nucleic probes, sometimes we can check susceptibilities also. The organism is resistant to first line drugs. But this all we should be familiar, and we should utilize depending on the availability and the socio-economic budget available to us. What methods we are going to use. Not every patient you are supposed to do IGRA. There are conditions where we are doing it. Culture remains the main thing. Main thing is tuberculosis skin test. That's the reason everyone should know how to do it. It's intradermal test done on the dorsal aspect of the forearm. Intradermal, we inject the purified pure protein derivative of the AFP. And then after 72 hours, we are looking for the duration. Induration is the hardness you have to feel and mark and then measure it in millimeters. Okay. We are not measuring the erythema. Redness is not, we are measuring not the redness. We are measuring the duration. And it should be measured and documented in millimeters, not negative, positive. So in duration greater than 5 millimeter is considered positive in all these patients, contact of infectious case. Okay. Abnormal chest X-ray, HIV, or other immunosuppression, primary immunodeficiency or secondary immunodeficiency. In duration of greater than 10 millimeters diameter, any person who is from a high endemic country, we are a high endemic country. Anyone who has 10 millimeters in our setting is positive. People who are living in prison, jail, nursing homes, institution, using drugs, okay, they have comorbids, okay, heart disease, diabetes mellitus, chronic renal failure, malnutrition, healthcare workers like us, okay, or people or children less than 4 years of age, anything greater than 10 millimeters is considered positive. 15 millimeters and above is positive, irrespective of any respect. Okay. Other important thing we have to remember is that positive skin test, when we are interpreting the positive skin test, we completely disregard BCG. BCG does not cause skin test to be positive for more than 3 millimeter in children who are above 3 years of age. Okay. And BCG, as you remember, is given at birth. So 3 years of age and beyond, if it is more than 3 millimeters, disregard completely the BCG status. Don't confuse. If people say, oh, he has a positive tuberculosis skin test, but this may be due to the BCG, no, completely disregard. However, TB can be false, the skin test can be false negative. And what are the reasons? These are the reasons. Okay. This is an important thing to remember. Sometimes people say this patient has classical signs and symptoms of tuberculosis, chest X-ray is positive, there is family history, but his skin test is positive. The negative skin test does not rule out tuberculosis. Okay. Viral infections like rubella, rubiola, varicella, influenza, typhoid, like bacterial infections, typhoid, leprosy, pertussis, and overwhelming TB can cause a false negative. Okay. Receipt of live viral vaccine recently, okay, MMRV. MMR, measles, mumps, rubella, varicella, these are live viral vaccine. Patients who have chronic renal failure, malnutrition, drugs, people who are on steroids and chemoplastic, very old or newborn patients who had surgery or burns or mental illness. False negative skin test can be due to other things also. That the injected material is not stored properly. The dilution was not good. It has already expired. Okay. Too little of injection was admitted. Delayed administration after loading the cell. Injecting subcutaneously or IM and not doing the intradermal test. It's supposed to be intradermal. Intradermal injection, especially in children, is very difficult. One person has to hold the child, stabilize the limb, and the other person injects the intradermally. False negative, other reason, inexperienced reader. He does not know what he is looking for. Very, very important to know. How to read the tuberculosis skin test, PPT or Markowitz test. This is what we are supposed to know. Conscious or unconscious bias is being reported in millimeters. So 6 millimeter, it might be positive in a patient who is exposed. 4 millimeter will be negative in a patient who is exposed. Error in reporting. These people write positive, negative. You don't have any clue how big it was. Positive might be someone reading 2 millimeters as positive. Okay? So it should be in millimeter. False positive. This is also very important. Okay? To know. Recent infection with non-tuberculosis mycobacteria. There are mycobacteria which are non-tuberculosis. Mycobacterium, Chirona, Marinium, Avium, what you name them. Okay. So these are completely different organisms. They are in the environment. If someone is giving you the history that they are doing gardening, they are swimmers, or they are cleaning swimming pools, then you have to remember that and interpret it intelligently. BCG, I told you the rule of 3. So any child who is more than 3 and BCG is more than 3 millimeters, it is positive. Disregard the BCG status. Treatment is very, very important. Remember using at least 2 bactericidal drugs. We should attempt all our efforts to isolate the organisms and do susceptibility testing. Culture should be done in all cases because sometimes we diagnose it correctly, but the drugs we are using, they are not effective. And we are seeing drugs, monodrug resistance, we are seeing very commonly in our settings. Multiple drug resistance, umbrella, we don't see. And extreme drug resistance, extensively drug resistance, umbrella, we don't see. At least I have not seen it. Now all treatment should be directly observed treatment to ensure good compliance. There are many NGOs who are working on this. So the drug is given to the child or the patient directly by a medical personnel, could be anyone, and it is documented that he swallowed the medication. Because one of the reasons for emergence of resistance is poor compliance. Sometimes people they start feeling better after 2 or 3 weeks of taking medicine. They become lax. They start skipping the medication, and the organism develops resistance. So we have limited drugs available for TB, and if resistance emerges and spreads, we will be in much more trouble than we are already in. These all medications we should be familiar. I'm not going to go into detail with each and every one of them. Just remember how they are being used. The main thing you have to remember is the toxicity. Isoniazid, hepatotoxic. So anyone who's taking it, you have to tell them that if they develop jaundice, right upper quadrant abdominal pain, their eyes become yellow, they have to do their LFTs, and we have to think about tailoring their antimicrobial therapy. Rifampicin is bactericidal, very effective drug, very well tolerated. Only thing you have to remember is that it causes orange discoloration of the body secretions. All these medications are used in combination. They are not supposed to be used individually. Pyrazinamide is a bactericidal drug, penetrates very well, okay, and toxicity is hepatic dysfunction, GI upset, skin rash. Ethambutol is bacteriostatic, okay, penetrates CSF poorly, and primary use when there is a highly likelihood of initial drug resistance. Toxicity, we have to remember reversible retrobulbar neuritis, blurred vision, and color blindness. All of these are reversible. So this is not a contraindication to use. They can be used safely even in pediatric age group where it is difficult to assess the visual acuity. Streptomycin is aminoglycoside, it's bactericidal, can be given only IM. Giving IM injections every day is very painful, okay? And it has severe toxicities. That's the reason it is not used orally, ototoxicity, nephrotoxicity. So have to be used intelligently by people who have experience. Most of the TB treatment is 4 drugs we are using for 2 months, and then for 4 months we are using 2 drugs. So this is important to remember. Most of the patients we are following them clinically. Sometimes we do LFTs, but not routinely in pediatric patients. Adult patients, LFTs are monitored regularly. Pulmonary or lymph node, disseminated TB, 6 months treatment, bone and joint TB, we are using for 10 months. TB meningitis is for 12 months. Okay, that is important to remember. Exposure. If someone is exposed to TB, what should we do? Okay, we have to establish the exposure. Did it occur? Someone was diagnosed with the TB in the classroom. Yes. Someone in the family is diagnosed with TB. Yes, the exposure has occurred. Same the people living in the same household, same classrooms, open TB. Yes, they should be. Then we should proceed to history and physical examination. The patient is having signs and symptoms or not. If having signs and symptoms, you worry. Okay. First thing to do is the tubercular skin test. Depending on the interpretation of the tubercular skin test and history and physical examination, chest X-ray is done. Chest X-ray is normal, then he only has infection. Okay, he was exposed, and there is no active disease. Chest X-ray is abnormal, he has TB disease. TB disease has to be treated. Okay, TB disease is treated. TB infection is patients are supposed to receive prophylaxis. Prophylaxis is monodrug, usually INH is used in people for 9 months. Now there are new regimens. We are using rifabutin and INH for 6 weeks. Can be done if available.
हेलो सर
जी जी
सर तमाम स्टूडेंट्स को हैंड रेस करना है तो उनके लिए इन्फॉर्म कर दो
जिसको रेस करना हो हैंड रेस कर दे और ये क्लास दिस इज द classification of the resistance. Okay, monodrug resistance, single drug first line, multiple drug resistance who are resistant to at least first line anti-TB medication, and extensively drug resistant who are resistant to at least these medications. First line, fluoroquinolone and aminoglycoside. So this is usually a nightmare. You have to use at least 6 to 8 medications, and you have to take for at least 2 years. So this is important. If anyone has any questions, please raise your hand. So we are almost done. This is supposed to be the last. There are